Hi, welcome to this lecture titled The Role of Image-Guided Biopsy When the Biopsy Makes a World of a Difference. This is a lecture I had given last week on a Sunday at a Bombay Orthopedic Society meeting where tuberculosis and mimics were discussed in a multidisciplinary setting. And so the idea really is, what do we do when we're faced with a focal bone lesion that looks like infection? And I'm going to focus mainly on the spine and the SI joints, but the concepts work across the body. Now, at this point in time, we do not have an MRI that can also do microbiology, nor are radiologists and orthopedic surgeons currently able to see organisms within the MRIs or CT scans. So until that happens, I will make a statement. No focal bone or spine lesion should be treated empirically without a biopsy unless a biopsy is absolutely not possible or the patient needs emergency surgery, let's say because the patient is quadriplegic or paraplegic and it's progressing rapidly, etc. And so in the Indian setting, this is what we often get: a patient who's got an infectious spondylodiscitis or spondylitis at L1-2 with a large abscess, which we would believe is tuberculosis unless proven otherwise. And so we aspirated pus, and this turned out to be PCR positive, that's gene expert positive, rifampicin not resistant, and culture positive TB. But on the other hand, and this is a case that I had put up about 2 years ago at ctbiopsy.com, a 26-year-old Indian studying in the US on vacation in India has an L5S1 infectious spondylitis. This would be TB unless proven otherwise. I did a biopsy from the S1 area, and this turned out to be coccidioides immitis, which this patient had picked up because they were studying in Arizona, where this is common, and this is what the fungal culture grew. So while we have classic findings on MR that would tell us that there's an infectious spondylitis, and then we have ways of differentiating pyogenic from TB, at the end of the day, in that individual patient, you are never able to tell. There is only a pre-test probability. So young patient, large collection, the pretest probability of TB is high. Patient over 60, multimorbidity, very little collection, that's more likely to be non-TB, etc. But if you're not able to tell for sure, and if you're not able to figure out the antibiotic and drug resistance or sensitivity of a particular organism, then how does it matter what you think the pretest probability is? Then the pretest probability only matters from the perspective of what material goes for which testing. So there are a bunch of questions that I posed to myself and the audience to get to this point that every lesion needs a biopsy. So the first question is, in an individual specific case, is it possible to know for sure whether it is TB or not? And here's an infectious spondylodiscitis at L5S1. And this turned out to be Acinetobacter. I used a pedicular approach here. Here's another L5S1 spondylodiscitis, classic appearance here: marrow edema, disc signal, soft tissue, etc. And here I used a transalar approach, and this was Salmonella paratyphi. D2-3 infectious spondylitis, TB unless proven otherwise in India. Biopsied this again with a transpedicular approach, and this was brucellosis. The second question is, let's say that you know it's TB, you're 100% sure, you've seen thousands of these cases, but in an individual specific case, can you for sure say whether that particular case is INH or rifampicin sensitive or resistant? So here's a 19-year-old classic TB, large psoas abscess, perivertebral collection here. And this was INH and rifampicin resistant on PCR, that's gene expert, LPA, and culture. And this is a TB naive patient to begin with. So how would you know if you had not biopsied or aspirated? So then the next question following both these is that in every patient, even if it looks like TB, should we always take material for aerobic, anaerobic, and fungal culture? So here's this patient who's got classic infectious spondylitis, has got another focal lesion here. There is a collection in the perivertebral region, went into the collection. Not only was it TB positive, rifampicin sensitive, the patient had staph hemolyticus as well. So here you have two organisms within the same patient producing the infectious spondylitis. And how would you have known unless you had gone in and biopsied or aspirated? And so then what are the other tests that we would use? You know, would we add biofire? Do we add 16S rRNA? So here's a 63-year-old D12L1 infectious spondylitis. This was a costovertebral approach, and this was Acinetobacter baumannii, culture positive, 16S rRNA positive. And this patient, where we only did PET scans, because the patient was admitted, it was difficult to get this patient into an MRI. This was a progressive infectious spondylitis at L4-5, suspected urosepsis. This was a CT on the day of the biopsy. I used a perivertebral, perifacetal approach here, biopsied both the disc as well as the perivertebral tissue. This was negative on 16S rRNA, but positive on biofire for Citrobacter. And so the point is, how much do you do? And I think that's where the pretest probability of TB makes a difference, because young patient, large collection, when you think that it's TB, you can then send for TB PCR, TB culture, and then maybe send for aerobic and mycolytic, which is the fungal in the media that the microbiology lab provides. But if you have an elderly patient where the suspicion is of an unusual organism or hospital-acquired disease, then I think it makes sense to also take additional material for biofire and 16S rRNA so that we do everything possible to get an answer. The next is forget TB versus non-TB. Can we reliably differentiate infection from tumor? So this patient was treated for tuberculosis empirically because they said, you know, young patient, 34-year-old, multifocal disease, what else can it be? You've got these classic spine body lesions, that's the SI joint. Patient improved a little bit, and then there was no change. And in fact, this MR was reported as perhaps partial improvement in the SI joint. Some of the iliac lesions had partly regressed, but there was a large sternal lesion here, which was interpreted as collections on either side. And they said, you know, we just continue the treatment. Patient comes back much later with a large, you know, with significant progression of the sternal lesion, destruction, etc. And I biopsied this. This was non-Hodgkin's lymphoma. This is an 80-year-old who has a complex left parotid malignant mass here, comes with a D2-3 lesion that was actually picked up on the PET CT. The question was, is this metastatic or not? And I biopsied this using a costovertebral approach, and this is TB, PCR and culture positive. So in a patient with a malignancy, suspected metastatic disease, this is infection that was actually incidentally picked up because the patient really was not symptomatic for that. And then patience, right? In today's day and age, everybody is in such a hurry to get an answer that it is sometimes getting tricky. And I had discussed this case a couple of years ago. It's there in the index and the table of contents at ctbiopsy.com. You can see this focal lesion here. There is actually, it is a sacroiliitis because there's marrow edema on both sides and a little fluid here. But this was somehow misinterpreted as an austere osteoma. And I can imagine how that mistake could have been made. But I mean, clearly there are erosions, and this was a sacroiliitis. Managed to convince them when they came for RFA that this patient needs a biopsy, did that. Now, GeneXpert was negative, PCR was negative. Histopath said granulomatous infection of possible mycobacterial etiology. So at least there's no tumor, austere osteoma, etc. The ID specialist wanted a repeat biopsy, and the parents were getting completely hyper. I mean, it was like, why don't we have an answer? We need to start treatment. We need to do this. Let's do a repeat biopsy. I said, come on. We have, I mean, the whole purpose is to also get material for culture. If you're not going to wait for the culture report, then what was the point doing the biopsy anyway? And then 4 weeks later, the culture was positive for MTB, and then the patient was anyway put on treatment because of the histopath report. And this was PCR rifampicin I mean, it was culture sensitive. So then they continued with the same lines of treatment. And so the question is, when PCR and other cultures are negative, but histopath rules out malignancy and gives you a definitive answer, do we rush in and repeat a biopsy, or just wait till the culture report comes in? And this is again an Indian thing, right? The 6 weeks culture report that comes, the samples after that, many microbiology labs at the most will keep for a couple of weeks. Now, if so the patient then has to go back, pay for the sensitivity testing, and get the DST done, which takes another couple of weeks and costs another 12 to 15,000 rupees. So whose responsibility is it to coordinate all this, right? So this is a student studying for NEET, right? Smart kid wanting to become a doctor has a unilateral sacroiliitis, biopsied the focal osteolytic lesion. It was PCR positive, TB rifampicin resistant. Then it turned out to be culture positive, but the patient had gone back to the Uttar Pradesh village. The orthopedic surgeon assumed they would get the report and act on it. Nothing was done. The time period for sensitivity testing lapsed. The samples weren't available anymore. And it was such a mess. So the patient lands up with this. Imagine the change that has occurred 4 weeks from now. We rebiopsied only to get material for culture. A huge cost to the patient again. And, just because she fell through the cracks. So if I have to answer all these questions, it is not possible in an individual patient to differentiate pyogenic from TB. You may have a high index of suspicion, which allows you to send the material to appropriately for different testing, but you can't really tell. You can't even tell whether, if it is TB, whether it's resistant or non-resistant. It is also possible for patients to have dual disease, dual organisms. So you do need to test for multiple organisms. Forget that. It's not even possible sometimes to differentiate infection from tumor. And so if your gene expert is negative, do wait for the culture report before rebiopsy or before resurgery, etc. And in an Indian setting, make sure the patients don't fall through the cracks for sensitivity testing on culture positive reports. And so I come back to this statement: no focal bone or spine lesion should be treated empirically without a biopsy, unless a biopsy is absolutely not possible or the patient needs emergency surgery. So the only question then is, when is a biopsy not possible? That's usually in the OC1C2 area, whereas every other spine segment, bone and joint is easily approachable safely and easily. So in the OC1C2 area or the CVJ area, usually you can find a way. But if you can't, it's a good idea to scan the rest of the skeleton, because 40 to 50% of all patients with CVJ TB will have some other focus somewhere in the body, in lower spine, SI joint, pelvis, that you can then safely biopsy as well. So for those of you who know that I also have posts at CT chest review, bone and soft tissue neoplasms, cardiac MR, etc. I have a link tree that links all the posts, including the link to my WhatsApp channel. And you're welcome to scan the QR code for that. That's my Atmaswast book, available on Amazon, including the Kindle edition. And thank you so much for listening to this. And I hope I've convinced you that every bone and spine lesion needs a biopsy.